Good afternoon, everybody. I would like to thank Professor Coates for his kind invitation to participate in this Congress. I would like to begin with, just a second. Sorry, introduction about pathophysiology. So, following the ingestion of food, cells in the gut release hormones called incretins, which circulate throughout the body in order to regulate glucose and calorie uptake. Two incretins are involved in this process, GAP and GLP-1. GIP is produced in duodenum in K cells, whereas GLP-1 in ileum through L cells. Both GIP and GLP-1 result in glucose-dependent enhancement of insulin secretion, and outside of pancreas, GIP and GLP-1 may also stimulate other tissues to influence food intake and lipid metabolism. So the term incretin was first described in 1932, and in 1964, a paper was published which demonstrated a significant and sustained rise in plasma insulin response following an oral glucose load compared to a parental glucose load. This phenomenon was later known as the incretin effect, and this accounts for up to approximately 65% of postprandial insulin secretion. On this graph, we can see that on healthy individuals, and shown on the left, when oral glucose is ingested, it causes a more robust insulin secretion, represented by the black line, compared to IV glucose, representing the red line. This difference is known the incretin effect. In subjects with type 2 diabetes mellitus, as shown on the graph on the right, the effect is reduced. So GLP-1 is a 30 amino acid peptide, and once it is released into circulation, it binds to a specific GLP-1 receptor, which is expressed in the pancreas, gastrointestinal tract, kidney, heart, and brain. Endogenous GLP-1 has a short half-life of approximately 1 to 2 minutes and is metabolized by enzyme DPP-4. In addition to the well-known insulinotropic property in response to nutrients in the gut, GLP-1 has a glucagonostatic effect as well, inhibiting glucagon secretion in the hyperglycemic and normoglycemic state, but not during hypoglycemia. Extrapancreatic properties of GLP-1 include slowing of gastric emptying, promoting satiety, and reducing food intake. GIP is a 4 amino acid peptide which is released in response to oral nutrients, especially carbohydrates and lipids. GIP, like GLP-1, has a short half-life and is inactivated by DPP-4. We know that GIP receptors are present in various tissues such as pancreas, adipose tissue, gastric mucosa, heart, adrenal cortex, bone, and brain. So, an ideal anti-diabetic medication should present with proven efficacy in lowering elevated glucose levels, promote weight loss, have low risk of hypoglycemia, and offer cardiovascular benefits. In this context, tirzepatide offers a novel mechanism of action of both hormone receptors GLP-1 and GIP. I would like to point out that at the moment, we do not really understand which receptor agonist is responsible for the effectiveness of tirzepatide. So it's a 39 amino acid linear peptide with mean half-life of approximately 5 days. And for that reason, this gives us the opportunity to use it once weekly. There were no clinically relevant effects on renal impairment based on tirzepatide pharmacokinetics. And for that reason, patients with renal impairment treated with tirzepatide may not require dose adjustments. So this graph shows the synergistic effect of GLP-1 in red and GIP in blue. Starting from the left, we know that many GIP receptors are present in adipose tissue. Clinical trials are on the way, and maybe tirzepatide will be used officially for the treatment of non-alcoholic fatty liver disease. Moving down the graph, we are all very familiar with the effect of GLP-1 in CNS by reducing hunger. However, while we know that there are GIP receptors in the brain, we do not know what the impact of hunger will be. Both GIP and GLP-1 act in pancreas to increase insulin secretion by lowering glucose. However, the effect on glucagon is opposite, and the impact remains to be seen. I would like to point out one organ where those two hormones do not overlap, which is the stomach. And finally, on the right side, with purple, are summarized actions of tirzepatide in subjects with type 2 diabetes mellitus. As mentioned before, GIP under conditions of normal and hypoglycemia stimulate glucagon secretion, but they do not do so during hyperglycemia. On the other hand, GLP-1 reduces glucagon secretion during conditions of hyperglycemia, but it does not do so during hypoglycemic conditions. We know that GIP may play a role in lipid metabolism. Because adipose tissue is involved in lipid uptake and release, it has been hypothesized that GIP may play a role in lipid metabolism. Some preclinical studies show that by enhancing the uptake of dietary triglycerides and free fatty acids into adipose tissue, GIP helps lower triglyceride levels in the blood. In doing so, it may induce weight-independent insulin sensitization. So various clinical trials have been performed so far, and many are ongoing. For the moment, I'm just going to highlight the key points for SERPAS study at clinical trials, SERPAS 1 to 5. I'm going to start with SERPAS 1, which is a double-blind randomized placebo-controlled phase 3 trial. And it examined it was a study of tirzepatide in participants with type 2 diabetes, not controlled with diet and exercise. And the goal was to evaluate the efficacy and safety of 3 tirzepatide doses, 5 milligram, 10 milligram, and 15 milligram as monotherapy against placebo over 40 weeks. 705 individuals participated in this trial with mean baseline HbA1c 7 to 7.9%. The mean age was 54 years, and they had a diabetes duration of approximately 5 years. The body mass index was 32. Depending on the tirzepatide dose, placebo-adjusted HbA1c reductions range from 1.9% to 2.1%, and weight reduction from 6.3 to 8.8 kilos. Up to 92% of participants taking tirzepatide achieved HbA1c below 7%, compared with 19% of those taking placebo, and up to 52% achieve levels below 5.7. Tirzepatide showed robust improvement in glycemic control and body weight without increased risk of hypoglycemia. The safety profile was consistent with GLP-1 receptor agonists, and this indicates a potential monotherapy use of tirzepatide for type 2 diabetes mellitus treatment. SERPAS 2 was studied tirzepatide versus semaglutide as an add-on therapy to metformin in participants with type 2 diabetes. 1,879 patients were assigned, and tirzepatide at the same 3 weekly doses was compared with weekly injections of 1 milligram semaglutide. The results showed that tirzepatide achieved up to 2.3% HbA1c reduction versus 1.9% reduction with semaglutide. Tirzepatide also resulted in significantly greater weight reductions up to 5.5 kilos, more than with semaglutide. In addition, many patients on tirzepatide exhibited improved lipid profile and improved blood pressure. Gastrointestinal untoward effects of tirzepatide were similar of those of GLP-1 receptor agonists. SURPASS-3, it's a study, a randomized open-label phase 3 trial, and eligible participants were adults with type 2 diabetes and a baseline of HbA1c 7 to 10.5%. They had a BMI of at least 25. They were all insulin naive and on treatment with metformin alone or in combination with SGLT2 inhibitor for at least 3 months before screening. In addition to the many study inclusion criteria, sub-study participants had a fatty liver index of at least 60. Participants had an MRI scan and were randomized in the main study to subcutaneous injection once per week tirzepatide of 5, 10, and 15 milligrams, or subcutaneous injection once per day of titrated insulin degludec. The primary efficacy endpoint was the change from baseline in at week 52 using pooled data from tirzepatide 10 milligram and 15 milligram groups versus insulin degludec. Moreover, at 52 weeks, the highest tirzepatide dose achieved an average of 2.4% reduction in HbA1c, which was superior to 1.34% reduction with degludec. In the 3 tirzepatide groups, an average weight loss of 7.5, 10.7, and 13 kilos respectively was seen, compared with an average 2.3 kilogram gain in the degludec group. Moreover, hypoglycemia rates were significantly lower with tirzepatide. These data provide additional evidence on the metabolic effects of tirzepatide. Following to SURPASS-4, this clinical trial studied tirzepatide once a week versus insulin glargine in participants with type 2 diabetes and increased cardiovascular risk, and taking metformin with or without an SGLT2 inhibitor. According to the press release, all 3 tirzepatide doses resulted in significantly greater HbA1c reduction than insulin glargine. Tirzepatide treatment also resulted in significantly more weight loss and less hypoglycemia. Finally, SURPASS-5 tried to assess the efficacy and safety of tirzepatide added to insulin glargine in patients with type 2 with inadequate glycemic control. So, in this trial, glargine plus the highest tirzepatide dose was tested, and the results showed that an average of 2.6% reduction in HbA1c, which was significantly higher than the 0.93% reduction seen with glargine plus placebo. An average weight loss of 11 kilos was seen with tirzepatide versus 1.7 kilos weight gain with placebo. Furthermore, subjects on tirzepatide reduced their insulin doses, whereas those on placebo increased them by 75%. So at the moment, according to FDA, the indications for tirzepatide is as an add-on to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus and obesity. Tirzepatide has not been studied in patients with history of pancreatitis, and it is not indicated for use in patients with type 1 diabetes. The contraindications are if someone has a personal or family history of medullary thyroid carcinoma, or in patients with multiple endocrine neoplasia syndrome type 2. We are all very familiar with that acute pancreatitis has been observed in patients treated with GLP-1 receptor agonists. Tirzepatide has not been studied yet. And FDA suggests that after initiation of tirzepatide, that we should observe patients carefully for signs and symptoms of pancreatitis. So now let's look at hypoglycemia rates when tirzepatide is added on other medications. In the SURPASS-4 trial, we see the highest rate of hypoglycemia when tirzepatide is added on glargine or sulfonylurea compared to metformin or SGLT2. Moving to SURPASS-5, tirzepatide is compared to placebo in participants who were already on basal insulin, as we said before, around 30 units, and also metformin. And what we see is that hypoglycemia was low, similar to placebo. Next, we're going to move to when and how much we should reduce insulin when adding tirzepatide. Using the SURPASS-5 findings and combining insulin recommendations, including prandial insulin, we can see the following recommendations. So, when adding tirzepatide to insulin, we should always consider patients' HbA1c. If it's below 8 or at 8%, we should consider reduction by 20%. If it's more than 8%, then no reduction is required. We should always reassess insulin dose at each tirzepatide dose escalation. Regarding prandial insulin, we should always consider risk of hypoglycemia and individualized dosing. If the subject is on low doses, less than 10 units per dose, we should always consider discontinuation. And for those who are on higher doses, those may benefit from 50% reduction of the dose. Regarding sulfonylureas, we should think about discontinuing or cross taper. So, the new dual GIP-GLP-1 receptor agonist tirzepatide has already shown promising results in type 2 diabetes mellitus. It is expected to enrich our therapeutic armamentarium. As we said before, tirzepatide efficacy and safety were assessed in phase 3 trials, SURPASS 1 to 5. Other clinical trials are currently underway in order to evaluate its use in other conditions. The scientific interest towards this effect is rapidly increasing, so I would say that the future is bright. Thank you.